Very good evening to everyone. I welcome you all today to today's Navigate Medico CME program. I would like to request Professor Umesh Kapil sir, Secretary of National Academy of Medical Sciences, to please deliver the welcome address.
Namaskar, good evening. It's a proud privilege to welcome all the experts, especially Dr. Yeppan sir, who has helped us earlier also with the Navigate program. We are most grateful to Dr. Ajay Duseja sir for taking the leadership role for organizing a series of lectures on management of common liver diseases. And we had very good participation. We also like to thank Dr. Nipun Verma, who is Associate Professor in the Department of Hepatology, PGI Chandigarh. Sir, we are very grateful to you for taking out time and helping us with Navigate program. A brief about the Navigate program I would like to share that we have almost 100,000 MBBS students who come out every year. About 8,000 get into the regular MD, MS courses, and about 6 to 8,000 get into the DNB program. So remaining about 80,000 plus, they do not have any opportunity and they do not get any CME to update their knowledge. So NAMS, if you recall, about 10 days back, there was a news item in Times of India that 20 lakh students have registered themselves for NEET PG examination. Now, these students need some guidance. Students need some help to update their knowledge. And keeping that thing in mind, we started this Navigate program. It's in the very initial stages, but we are finding it successful. And we find that the students, they're really getting benefited with this Navigate program. With these few words, I would like to hand over back to Manali to continue the proceedings. Dr. Manali, please.
Thank you, sir, for this valuable initiative for the students. Now, I would like to invite the chairperson for today's session, Professor C.E. Yeppan, Professor and Head, Hepatology Department, Christian Medical College, Vellore. It is my pleasure to introduce Sir. Sir is the member of Editorial Board of Indian Journal of Gastroenterology, Gastroenterology, Hepatology, Endoscopy and Practice Journal, Hepatology International Journal. Sir was also the Medical Superintendent of Christian Medical College, Vellore. Sir has received Young Clinician Award awarded by Indian Society of Gastroenterology, Sheila Sherlock Fellowship Award awarded by European Association for the Study of Liver for the year 2004 for the study Do IgA cardiolipin antibodies contribute to pathogenesis of non-cirrhotic intrahepatic portal hypertension? Sir has delivered Professor D.N. Madan Gopalan oration at annual meeting of Tamil Nadu chapter of Indian Society of Gastroenterology held at Coimbatore on 8th March 2020 on the topic Plasma Exchange to Treat Liver Failure. Sir has nearly 50 publications and chapters in the book. Over to you, sir.
Thank you. Let me first of all thank the National Academy of Medical Sciences for this opportunity to participate in this very new and interesting initiative, which is important and is highly likely to benefit the young medicos who are passed out and are looking forward to update their knowledge. So it is my pleasant duty to introduce Nipun. Dr. Nipun Verma is Associate Professor at the Department of Hepatology in PGI Chandigarh. And I have interacted quite a bit with Nipun and I have admired his qualities. It's true, that's what's written here, that he would come across as a clinician scientist, and that is very true. Now, Nipun has trained in hepatology and liver transplantation, both at PGI Chandigarh, as well as in Pittsburgh in USA, which is where Dr. Thomas Tarsal first pioneered the treatment of liver transplantation for the whole world. So he has very highly specialized training in these very good centers. And Nipun has a keen researcher. His areas he's passionate about, one of them is artificial intelligence, and he is somebody who is keenly taking up AI in different applications in liver diseases in India, and apart from liver failure, as well as other areas of interest. So I'm sure the talk that he's going to deliver on management of alcoholic hepatitis will be of immense use to the students. Over to you, Nipun.
Thank you very much, sir. At the outset, I would like to thank the organizers, NAMS, Professor Sareen, Professor Kapil, Dr. Akshay, Dr. Yeapan, Dr. Ajay, for giving me this opportunity. So today, my job is to speak on the management of alcoholic hepatitis. And I hope you can see my slide.
Yes, your slides are visible.
Okay. So my job is to speak on management of alcohol-associated hepatitis, and I bring greetings from PGIMR Chandigarh. There are no disclosures pertinent to this talk except that Dr. Sunil Taneja, who has given me valuable inputs for this presentation. So I'll be taking you through the burden of disease of alcoholic liver disease and alcohol use disorders. What is the natural history of alcoholic liver disease? How do we diagnose patients with alcoholic hepatitis? How do we stratify these patients, and what are the treatment strategies in these patients? Now, starting with the terminology, the term alcoholic is quite stigmatizing because it undermines the patient's dignity and self-esteem. Therefore, the emerging literature from Europe as well as America has replaced the term alcoholic with alcohol use disorder, and alcoholic liver disease with alcohol-related liver disease, and alcoholic hepatitis with alcohol-associated hepatitis. The burden is quite worrisome because over the year, worldwide, it has been shown that 3.3 million deaths every year happen because of harmful alcohol abuse. And about 6% of all deaths is because of alcohol. And that is constituting around 7.6% in men and 4% in women. It has a global impact over more than 200 diseases and different types of injuries. And most important diseases which alcohol affects to the body include the cardiovascular diseases, injuries, gastrointestinal diseases, and mainly in which cirrhosis makes a dominant cause of morbidity and mortality. So in India, there are several states where alcohol is banned, but there are several states which are alcohol guzzlers. And Kerala and Punjab is amongst one of them. In India, the alcohol use is quite prevalent and increasing over the time. And the more so it is problematic because the persons drinking under the age of 21 years has increased over the last decade from 2% to 14%. And problem is that the age at which they start drinking is close to 13 years. It is so unfortunate to see a wine or beer shop at every corner of a sector or a city, whereas you don't find hospitals or schools with that much frequency. Regarding liver-related deaths in Asia-Pacific region, if we can see that this bar gram, which demonstrates that in India, alcohol remains the second most common cause of liver diseases. And alcohol constitutes around 22% of all deaths because of chronic liver disease. The deaths due to alcohol-related cirrhosis has increased in India from by 22.7%. And the per capita, this is because the per capita alcohol abuse in adults more than 15 years of age has jumped significantly from 1.8 liters that was there in 2000 to 5.6 liters in 2016. There are several terms associated with drink and drinking, so one should understand the terminology before moving ahead for the alcoholic liver disease. Quantification of alcohol is quite important, and it is variable from country to country and region to region. Grams of alcohol, that is ethanol, is quite precise, but it is difficult to calculate in a given drink. And the time and the frequency with which persons consume alcohol determines the kind of liver injury they develop. In general, one drink is defined as around 10 grams of pure alcohol, that is ethanol. Harmful drinking is defined as when the alcohol use is causing damage or physical or mental damage to an individual. Heavy alcohol intake is defined as per literature of consumption of more than 60 grams of pure alcohol on one occasion. And this is very important question which is often been asked in the rounds, is what is the definition of binge drinking? A binge drinking is consumption of more than equal to 4 drinks for women and more than equal to 5 drinks in men in a time span of 2 hours. And that actually corresponds to rise in ethanol levels in the blood by 0.08 milligram per deciliter. There are several forms of alcohol that is available, and the unit of alcohol is variable from region to region, country to country, ranging from 10 to 15 grams. Approximately, if one has to take out from the history during the bedside examination, what kind of alcohol, how much grams of alcohol patient is consuming, then average of 330 ml of beer, 150 ml of wine, that is 25% weight by volume, and 30 ml of whiskey, close to 45% weight by volume, or 30 to 40 ml of desi alcohol is equivalent to 1 unit of alcohol. The safe limits, although there is no safe limit for humans, because any one drink can lead to increased risk of cancers and other injuries. But for the liver, it has been defined in literature that 1 drink for women and 2 drinks or less for men every day has been shown to be associated with relatively safer liver outcomes. Heavy drinking, as I defined previously, 15 drinks in a week for men and 8 drinks or less in women or more in women are considered as heavy drinking. And binge drinking, as I said, 4 drinks in women and 5 drinks in a men over 2 hours. So if a person is consuming alcohol in a significant amount of dose, that is more than 3 drinks per day or in men and more than equal to 2 drinks per day in women, then 90% of these individuals will develop fatty liver, which is called steatosis. About 1/3, 20 to 40% of these individuals will progress on to develop fibrosis in the liver, and about 1/3 or less than 1/3 of these patients will progress on to develop cirrhosis. And those who develop cirrhosis, around 20 to 40% of these individuals decompensate, and around 3 to 10% of these individuals develop hepatocellular carcinoma. So during this whole process of transition from fatty liver to fibrosis to cirrhosis to decompensation, there is a very peculiar state amongst patients with alcoholic liver disease, is a state called alcoholic hepatitis or alcoholic steatohepatitis, which is histopathological term. This state is quite severe, and that can be seen in an underlying liver, which can be steatotic, the underlying liver, which can be fibrotic, or underlying liver, which can be cirrhotic, or underlying liver, which is already decompensated. So point to understand is that alcoholic steatohepatitis or alcoholic hepatitis is a state or a phenotype that can happen in any of the underlying diseased state of liver. And the outcomes is probably different in all the states. I will come on to this concept and the concept of acute on chronic liver failure because of alcoholic hepatitis in my subsequent slides. So it is important to understand that this natural history of alcoholic liver disease is quite somewhat similar to non-alcoholic fatty liver disease, where patients can also develop steatosis, fibrosis, cirrhosis, and decompensation. But the point to note and the differentiation from non-alcoholic fatty liver disease is this state, which is severe inflammatory state of alcoholic hepatitis, which leads to high short-term mortality and organ failures quite often in patients with alcoholic liver disease. I hope I am clear by now that this state is quite severe. So this is a serious state that can develop in heavy drinkers, that is characterized by the phenotype of these patients are characterized by rapid onset of jaundice, associated with generalized systemic symptoms in terms of malaise, anorexia, development of systemic inflammatory response, and it is quite often associated with high short-term mortality ranging from 30 to 50% in a short span of 90 days, despite cessation of alcohol. So natural history of these patients who develop alcoholic hepatitis, roughly 1/3 of these individuals progress despite stopping alcohol, 1/3 remain static, and near about 1/3 or 20% of them improve spontaneously. There is a considerable overlap with the definition and presentation of acute on chronic liver failure, which I will be coming to this concept again and again in the subsequent slides. And there are fewer therapeutic options for this syndrome. If we look at the pathophysiology of this syndrome, alcoholic hepatitis has three most important axes. First and foremost axis is increased amount of cell death because of alcohol and its metabolic products, acetaldehyde and alcohol dehydrogenase enzyme, which produces adducts, and that causes different forms of cell death, which releases damage-associated molecular patterns inside the liver. Second important axis, which is impaired or affected in patients with alcoholic hepatitis, is impaired liver regeneration. Third important axis which is impaired is the gut dysbiosis, where the bad bacteria inside the gut increases and the good bacteria goes down, which releases a lot of pathogen-associated molecular patterns inside the portal vein that goes inside the liver, incites the liver inflammation. More so, the damage-associated molecular patterns released from excessive cell death also incites the liver inflammation. Neutrophils, monocyte macrophage system gets affected. It invites a lot of systemic cytokinemia. Cellular and soluble components of immune system get affected. Coagulation became deranged. There is a lot of pro and anti-inflammatory responses that is highly dynamic, and a state of immune paresis developed in these patients because of persistent activation, such that the functional capacity of immune system, especially the innate immune cells, characterized by neutrophilic phagocytic capacity, goes down, which actually correlates with multi-organ failures. And this syndrome, where the patient develops multi-organ failures, is defined as acute on chronic liver failure, according to European group. And death or survival is dependent upon host or the body's response to conserve or to retrieve back from immunopathological damage, which because of three key insults which happens in these patients. The definition of alcoholic hepatitis as per American guidelines is divided into three major groups: definite alcoholic hepatitis, probable or possible. The definite alcoholic hepatitis is always and always biopsy proven. Probable diagnosis is quite often we make when patients present to us with heavy alcohol intake, defined as more than 40 grams of alcohol in female, more than 60 grams of alcohol in males, for more than equal to 6 months, and they present with a short-term span, within a short span of 60 days after the last alcohol intake, with the onset of jaundice. And this jaundice is usually more than 3 milligram per deciliter, with an elevation of AST to ALT ratio of more than 1.5, and the both values are often less than 400. It is important to note that if the AST values or the ALT values are beyond 400, one must exclude viral hepatitis and concomitant injuries because of drug-induced liver injury or herbal drugs, which often these patients consume. The confounding factors which can mimic the similar presentation and needs to be ruled out before making a probable diagnosis of alcoholic hepatitis include ischemic hepatitis, where there is often a history of shock or severe gastrointestinal bleeding, presence of elevated AST, ALT with normal alkaline phosphatase, and a family history suggestive of Wilson's disease, drug-induced injury, and then patient should be looked for atypical sign and symptoms, atypical investigations such as AST less than 50 or AST, ALT more than 400. It is important to note that ALT levels does not rise in patients with alcoholic hepatitis as opposed to AST that rises out of proportion. And the reason is the pyridoxal phosphate because of vitamin B6 deficiency, which happens in alcoholic liver disease patients. Another key important finding to note is that there are certain atypical presentations of alcoholic hepatitis, which is called alcohol foamy degeneration, where AST, ALT levels can reach in more than 10 times the upper limit of normal. And this is the rare presentations, although it has been described that a lot of foamy degeneration amongst the hepatocyte can lead to elevated levels of AST, ALT. But largely for the definition of probable alcoholic hepatitis, one must fulfill this criteria. And patients who have confounding factor with probable criteria, you call them as possible alcoholic hepatitis. According to a recent study published, review article published in NEJM, they suggested different investigations for ruling out the confounding factors, such that imaging for ruling out biliary obstruction, history of drug intake, investigations for viral hepatitis B, C, and HAV, autoimmune workup, ischemic hepatitis, and then proceeding with the diagnosis of probable alcoholic hepatitis. What are the group of patients who require biopsy? The patients who have confounding factors or meriting a randomized trial or recruited in studies, they are the ones who require histological confirmation. Because biopsy is not without problems in patients with alcoholic liver disease. There's a lot of coagulopathy and thrombocytopenia that can increase the risk of bleeding in these patients. Therefore, biopsy is limited to a select individuals where there is a confounding etiology and there is a need for recruitment into certain trials. So liver biopsy in patients with alcoholic hepatitis is characteristic. And there you can see a lot of steatosis, especially microvesicular steatosis near the pericentral area. It is predominantly central pathology. So you have liver zonation, which previous speaker has described in his, Dr. Sahaj must have described. There is a lot of neutrophilic infiltration in patients with alcoholic hepatitis, bilirubinostasis, presence of perisinusoidal fibrosis, and development of cirrhosis in patients who progress on to an advanced stage of alcoholic liver disease. Patients with alcoholic hepatitis has a characteristic finding in histology that can be used for stratifying the severity of these patients. It is important to note that the underlying damage, which I mentioned in the natural history of alcoholic liver disease that the presence of fibrosis or cirrhosis determines the outcome. And on histopathology, it has been shown that patients who have bridging fibrosis or cirrhosis are given 3 points in this histological severity scoring system, which was proposed in 2015. So it has been demonstrated to be a poor prognostic factor. Bilirubinostasis, if canalicular or ductular, given 1 point, and if it is hepatocellular, 2 extra points are given. Intriguingly and counterintuitively, you can see that absence of polymorphonuclear cell neutrophilic infiltration is a good prognostic sign. That is, if there is a severe prognostic, severe PMN infiltration, then you have a patient with alcoholic hepatitis with good prognosis. Presence of megamitochondria likewise has been associated with good prognosis. And if you classify these patients based on severity scoring, the severe score corresponds to 6 to 9, has a very poor prognosis of 50% survival at the end of 90 days. There are several other scoring systems for predicting severity of alcoholic hepatitis. And one must understand that it is mandatory for all patients with alcoholic hepatitis to stratify into severe or non-severe groups at presentation, because the therapies and the modalities are quite different and the outcomes are also quite different. So there are several static models ranging from Madrid's discriminant function, MELD score, Glasgow score, ABIC score, and alcoholic hepatitis score, which I just mentioned. And then there are dynamic models which are used for looking at the response of steroids, called Lille score. And then there are combination of MELD and Lille score, which has been proposed by Dr. Kant. Amongst these scoring systems, if we see the 2 most important criteria which are often used for predicting prognosis in patients with alcoholic hepatitis are MDF and MELD score. MDF is calculated by 4.6 times the prolongation of prothrombin time plus bilirubin levels in milligram per deciliter. Patients with more than equal to 32 of this score is characterized as severe alcoholic hepatitis patients, and they have a poor prognosis ranging from 20 to 30% of mortality at the end of 30 days. MELD score is another important criteria for defining prognosis, which is calculated by bilirubin, INR, and creatinine. And the score of more than equal to 21 has been associated with more than 20% probability of death. And this is quite often available in all the calculators, and MD-Calc is one of the very interesting calculator for calculating all the kind of scores you have in gastroenterology. Now, how literature fare between these scoring systems, MELD and MDF? A recent study by Dr. Batalar's group has shown that MELD score outscores the performance in terms of predicting prognosis at 28 days or 90 days as opposed to MDF score for mortality in patients with alcoholic hepatitis. So they showed that an optimal cutoff of 25 and above for categorizing patients at high risk of mortality in alcoholic hepatitis. So looking at the treatment options of alcoholic liver disease in general, and then I will bring my focus to alcoholic hepatitis. So patient who has a normal liver, we can even start with a primordial prevention not to drink alcohol and not to go into a stage of steatosis or any kind of liver disease. But if the patient has developed fatty liver because of excessive alcohol intake, their abstinence, good nutrition, and control of its metabolic risk factors will revert the state of fatty liver in almost all persons. The persons who develop fibrosis and steatohepatitis with or without underlying decompensation, the use of steroids in patients with severe alcoholic hepatitis has been shown to be beneficial, and I will come to the details of steroids in subsequent slides. NAC is then N-acetylcysteine is an antioxidant treatment, has been shown to be beneficial in combination with steroids up to short term. And again, I will come to these studies. zinc and supportive treatment and liver transplantation in select individuals have been shown to be a treatment armamentarium for alcoholic hepatitis. Patients who develop cirrhosis and related complications, the complications need to be managed as per the guidelines, and especially infections and liver transplantation are the ultimate things which needs to be seen in patients with decompensated cirrhosis because of alcohol. And those who develop hepatocellular carcinoma, there is a whole set of guidelines for treating such patients. So patients with alcoholic hepatitis is largely being treated with steroids, nutrition, abstinence, and liver transplant. So the standard treatment for alcoholic hepatitis starts with abstinence, nutrition, pharmacotherapy predominantly related to corticosteroids. Pentoxifylline, age-old medicine TNF inhibitor, has been used, but now it is out of obsolete. And I will come to the studies where it has shown not to be beneficial right now in patients with alcoholic hepatitis, and liver transplantation in a select individuals. Emerging therapies for alcoholic hepatitis range from targeting gut-liver axis, regenerative therapy, anti-inflammatory agents, and extracorporeal devices or plasma exchange. But this is the standard way of teaching. I will take you in the next subsequent slides with an interesting concept of novel therapies in alcoholic hepatitis. It is to understand that even despite with the existing therapies, we have a very high short-term mortality in any patient with alcoholic hepatitis who presents to us. These patients have quite a high morbidity and mortality. Abstinence alone is often insufficient. Around 20% individuals improve with abstinence to the normal state or somewhat better state. Nutrition is critical, but practically it is quite challenging to give patients with alcoholic hepatitis a good amount of nutrition, and about 70% of these individuals do not get the appropriate calories according to the literature. Steroids have been shown to be beneficial, and the patients who respond, and the responders have a very good survival benefit at the end of 1 month, but the patients are often ineligible for steroids, and around 50% of these individuals have unpredictable response to steroids. So steroids has a very limited role also in patients with alcoholic hepatitis, and I will come on to these patients who are the best candidates for steroids and the newer therapies I will be coming to. So I'll bring to you a concept called pyro concept and use this concept and make a story of treatment in alcoholic hepatitis. So in any disease, if you look at the kind of damage which any disease causes, it ranges from a state of predisposition where there are risk factors in a given individual which predisposes to develop a severe disease. Then there is a excess called injury, which happens because of various kind of insults. Response, which happens to where the body responds to different sorts of injury. And then there are outcomes in the form of organ failures because of the kind of injuries which a patient gets. So in this concept of pyro, predisposition, injury, response, and outcomes in alcoholic hepatitis is quite pertinent. And as you can see in the subsequent slide, that predisposition of a given individual to develop alcoholic hepatitis or severe forms of alcoholic liver disease is often determined by their risk factors. As I mentioned, majority of patients develop alcoholic fatty liver, but around 20 to 40% of these individuals progress on to develop severe forms of alcoholic liver disease, that is fibrosis, cirrhosis, or decompensation. Therefore, there are several risk factors which determine these outcomes. Genetics is amongst one of them. Gender, female gender has been associated with significant amount of alcoholic liver disease, and there are several theories ranging from gastric enzymes of alcohol dehydrogenase to a metabolism of alcohol, differential metabolism of alcohol in females versus males, presence of metabolic syndrome, sarcopenia, extent of liver damage, the degree of fibrosis or decompensation also determines the kind of injury a patient develops. So I am giving you the concept how a patient with alcoholic hepatitis progresses and the risk factors, so that whatever we can do to prevent the progression or limit the organ failures in these patients can be done at the stage of predisposition. We can't do much about genetics, can't do much about gender, these are non-modifiable risk factors, but we can do a lot about sarcopenia, metabolic syndrome, and control of immune functions in patients with liver disease. Then there are various types of injuries which happen in alcoholic hepatitis. A patient who comes to us with a bilirubin of more than 3 with a recent alcohol intake, not only alcohol, there are several other excesses in the body which adds on to the injury in a given individual. And that includes infections, gut dysbiosis, development of acute upper GI bleed, intake of alternative medicines. Quite often you see people taking LIV52 and other sorts of Ayurvedic kadas, and drug-induced liver injury because of antibiotics and painkillers these patients often take because of pain in abdomen or otherwise. So we can do a lot about controlling the injuries in these patients with alcoholic hepatitis. And I'll be coming to the details individually. Third important axis where alcoholic hepatitis patients have a key avenue, key opportunity for improving the outcomes is the response of human body to a given insult. And the given insult, as I said, can be alcohol, infections, upper GI bleed, or DILI. The response is in the form of systemic immune dysfunction, also at the level of liver inflammation, and includes both cellular and soluble factors. At the level of liver, there is a lot of cell death, poor liver regeneration, a lot of problems in the cellular metabolism, a lot of problems in the bile acid metabolism, which we all can target for development of novel therapies in patients with alcoholic hepatitis. And the end organ of human host response to the given insult, that is the alcohol, can be in the form of end organ dysfunctions or failure, often due to which patients present to us, and we take care of these organ failures with organ support therapies and liver transplantation if patient is not improving. So amongst the different factors which predispose to severe forms of alcoholic liver disease in patients who consume alcohol, genetics is very important, and there are a beautiful review article by Dr. Kulkarni's group has shown that different polymorphisms in PNPLA, TMSF6, oxidative enzymes, inflammatory enzymes, alcohol dehydrogenase enzymes can predispose, and the whole list has been described in this, but we can't do much about genetics in a given individual at the moment, at least. And although we can develop certain prediction algorithm using enzyme polymorphism using something called polygenic risk scores for a personalized treatment for a given individual, where if that scoring system is positive, then one must curtail the alcohol from the outset so that he is prevented from developing severe forms of alcoholic liver disease. Metabolic syndrome is an independent risk factor for severe liver-related injury in patients who consume lots of alcohol, and obesity and metabolic syndrome both are independently associated with liver-related mortality. And this is something which we need to control in every alcoholic liver disease patient. And I will come to this control in the nutritional aspect of my talk. Sarcopenia, as I said, is an independent predictor of development of multi-organ failures in patients with alcoholic liver disease. And according to this study, when they combined sarcopenia with cystatin, which is another novel marker of inflammation, they showed that the patients who have sarcopenia and this cystatin of more than 1.5, they had a very high incidence of development of alcoholic ACLF. And these patients who developed alcoholic ACLF, they had a very high mortality ranging from 50%, as compared to persons who do not have sarcopenia. So sarcopenia is an important predictor of development of multi-organ failures and immune dysfunction in patients with liver disease. As I mentioned previously, the presence of underlying fibrosis, cirrhosis, and decompensation can determine the outcomes. And there is a quite important need to differentiate a pure alcoholic hepatitis from alcoholic hepatitis patients presenting as ACLF. Not to confuse you, there are two definitions or rather multiple definitions for ACLF. The European group have defined ACLF as acute deterioration of chronic liver disease patients relating to a precipitating event, which can be alcoholic hepatitis, and that is associated with multi-system organ failures. And these are the group of patients who have a very high short-term mortality ranging from 50 to 100%, depending upon the number of organ failures they have. On the other hand, a partial group defines jaundice, the ACLF, as acute hepatic insult. The insult has to be hepatic, like in alcoholic hepatitis patients. Alcohol is an hepatic insult, manifesting as a jaundice of bilirubin more than 5. In alcoholic hepatitis, the entry criteria was 3, but here in ACLF, the entry criteria is more than 5 milligram per deciliter. These patients must have coagulopathy with an INR of 1.5, which is not there in the definition of alcoholic hepatitis. But a patient with alcoholic hepatitis who develops INR of more than 1.5 with a bilirubin of more than 5, and that is complicated within 4 weeks by ascites and or encephalopathy, these patients are called as ACLF according to OPASL criteria. And these patients also have a very high short-term mortality. A patient who develops ACLF has a very poor prognosis in patients with alcoholic liver disease. A patient who develops grade 3 ACLF, which is defined as 3 or more organ failures, according to Cliff-Sofa criteria, the mortality is close to 72% in these individuals. Patients who develop 2 organ failures are called ACLF grade 2. They have a mortality of close to 58%. Patients who have a 1 organ failure or single renal organ failure, they have a mortality of close to 30%. And the persons who have no organ failures or pure alcoholic hepatitis, these patients have a good prognosis of mortality of close to 20%. But this 20% is also very high, mind you. So what are the predictors which indicate that the person with alcoholic liver disease can go on to ACLF? Infections is an important predictor of the development of ACLF. So one must curtail infections in patients with alcoholic hepatitis. And the predictors of death in patients with ACLF included infections, as well as presence of ACLF and high disease severity score, that is the MDF score, because of alcoholic hepatitis. It is not uncommon to see ACLF. Around 50% of these patients have ACLF, that is the multi-organ failures at presentation, and close to 1/4 of these individuals develop ACLF on follow-up once these patients come to us. So one must understand that alcoholic hepatitis is just a phenotype, and these patients can progress on to develop multi-organ failures with high short-term mortality, that is called ACLF. So one must identify a patient, what stage he is coming to us, and the management is different, quite different at the 2 stages where the patient presents to us. So what determines the progression to ACLF? As I said, sarcopenia is one of the important predictor. Infection is one of the important predictor. Another important predictor or a scoring system one can use is CLIF-C-AD score. This CLIF-C-AD score is calculated based on age, creatinine, INR, WBC, and sodium. And based on this scoring system, if the score is more than equal to 60, these patients have a very high risk of development of ACLF. So it just reflects the kind of liver injury, synthetic defect of the liver, the kind of inflammation a patient is having, the kind of organ failure, that there is the creatinine which is high in a given individual, which determines that the patient is going to progress on to multi-organ failures or not in a patient with alcoholic hepatitis. Several advanced techniques have shown that the certain metabolites can also predict, but it is out of purview of today's presentation to tell you that there are different metabolites which can predict ACLF. Apart from predisposing factors or risk factors which can lead on to alcoholic hepatitis and severe forms of alcoholic liver disease, injury because of alcohol is quite important, and abstinence determines the long-term survival of patients with alcoholic hepatitis. And in patients with alcoholic hepatitis, any amount of alcohol, even beyond 1 gram per day, is associated with high odds of death. And if the person is taking more than 100 grams per day, despite having alcoholic liver disease, then the risk of outcomes, risk of death is 6 times the odds of death rather than risk. The odds of death is quite high, 6 times higher than the controls, those who are not taking alcohol. So basically, continued alcohol abuse in patients with alcoholic liver disease increases the risk of bleeding, decompensation such as ascites, encephalopathy, development of cancers, and death. And complete abstinence is the something which is recommended in patients with alcohol. It is important to understand that the patients who stop taking alcohol, they follow 3 trajectories. 1, they can be rapid risers. 2, static or fast followers. And what are these? This is defined based on the bilirubin levels at day 7 of their presentation. Persons who have a bilirubin jump of more than 1.2 times the baseline value are called rapid risers. They have a very poor prognosis. Patients who have a 0.9 to 1.2 times the baseline value at day 7 are called static patients. And fast followers are someone who respond very well just with abstinence and nutrition. And there is no need for corticosteroids in these patients who are fast followers, where the bilirubin levels goes below 0.8 times the baseline value at day 7. And if you look closely by this study by Dr. Batala's group, there they showed that those who were fast followers had a 79% survival, and these patients have no benefit from steroids. So patients who are static or rapid risers are the group of individuals where the need for steroids or controlling the response, that is the inflammation, is recommended in patients with alcoholic hepatitis. There are several drugs for ensuring and preventing alcohol abuse and continued alcohol use in patients with alcoholic hepatitis. And this is a very important area where every physician must be comfortable in treating patients with alcoholic hepatitis to prevent alcohol use. One must talk to the patients every time they visit and ask about the alcohol use they are having, and the drugs which are recommended for preventing relapse in these patients can be prescribed and should be prescribed by physicians or the hepatologists or gastroenterologists who are looking after the patients. Baclofen is a drug which has been shown to be liver safe in preventing the alcohol relapse, and the usual starting dose is 10 milligram TDS and can go up to 80 milligram once daily. And it has got minimal hepatic metabolism, so it's quite safe. Acamprosate is another drug which has been shown in a recent randomized controlled trial with an initial dose of 666 milligram TDS, and it is also hepatic safe. Mind you, disulfiram should never ever be used in patients with a liver disease with a high bilirubin, because it has a potential to cause liver injury, ACLF, DILI, drug-induced liver injury in patients with underlying liver disease. And other drugs remains experimental and used variably by the experts, drug de-addiction experts. Apart from drugs, there are several psychotherapies, motivational therapies, and cognitive therapies, and several studies have demonstrated if you integrate the alcohol use disorder management along with the ALD management in alcoholic hepatitis patients, the outcomes are superior, their survival is superior, their risk of relapse is lower, and these patients fare better as you follow up these patients. Nutrition is an important aspect of managing and controlling the injury, and we are focusing on the injury aspect of alcoholic hepatitis. And the age-old study published by Menden and Hall in 1995 that showed that persons who take alcohol, the calories of less than 1,000 kilocalories per day, they have a very high mortality. And the persons who take a good calorie intake of more than 3,000 has a very good prognosis and only 27% mortality. Several other studies, including enteral nutrition, has shown to improve outcomes, especially in individuals who take a calorie intake of more than 21.5 kilocalories per day and at least 0.8 grams of proteins per kg per day. And therefore, it is recommended to give adequate calories and proteins in patients with alcoholic hepatitis. All patients with alcoholic hepatitis should be given a prescription regarding restriction of salt in patients who have ascites and adequate amount of calories and proteins. They should not be restricted with glucose-based diet or bully-based diet or sugarcane juice. And these are the kind of patients who require good amount of milk or milk-based products, and then calories in a good quantity, which I'll be coming to in the next slides. Micronutrient deficiencies are quite often seen in these patients with alcoholic hepatitis, and therefore thiamine, especially in the high doses, 100 to 200 milligram thrice daily, is recommended in acute phases of alcoholic hepatitis, more so in alcohol withdrawal syndrome patients. Folate, B12, and vitamin K and pyridoxine needs to be supplemented. Zinc is another metal which is recommended in these patients for maintaining the intestinal integrity. And if we give a lot of calories and protein in these patients, improve their sarcopenia, reduces the risk of infections, and improves the liver regeneration in patients with alcoholic hepatitis. Nutrition has significantly shown in a meta-analysis to be superior in improving the outcomes. Therefore, the European guidelines recommend 35 to 40 kilocalories per kg per day to a patient with alcoholic hepatitis with a protein of 1.2 to 1.5 grams per kg. And the kind of protein recommended is the protein, vegetable-based proteins rather than animal-based proteins, more so in patients with encephalopathy. And these are the recommendations. One can go and see in the EASL guidelines for cirrhotic patients and critically ill patients. Important point to note is that oral branch chain amino acids are recommended in patients with encephalopathy and severe sarcopenia who are not able to meet their daily protein intake. Infections is an important insult in patients with alcoholic hepatitis, and there in the subsequent NAMS lecture, I'll be taking you to the details of infections. But one must understand that any patient who comes to us with alcoholic hepatitis with systemic inflammation, one must and always rule out infection with the clinical criteria, with different investigations, biomarkers, and then treat these patients early with the antibiotics within 3 hours of presentation, which can improve their outcomes as shown by Dr. Piano. Gut dysbiosis can lead to a lot of added insult in these patients, and probiotics and prebiotics, symbiotics have been tried in patients with alcoholic hepatitis, but unfortunately they are insufficient alone to improve the outcomes. Fecal microbiota transplantation is an experimental therapy that has shown to improve outcomes in selected group of individuals with alcoholic hepatitis. PGI, we also tried this, showed some benefit at 1 month. Different probiotics have shown to improve the microbiota of alcoholic liver disease patients, improve their inflammatory profile, but it is far from improving the overall mortality of these patients. These are experimental therapies, which I am not going into details. Upper GI bleed is another thing which can add on to the insult in alcoholic hepatitis patients, and there it is recommended to control with vasopressors and endotherapy in these patients. Response is quite often dealt with corticosteroids in alcoholic hepatitis patients, and the steroids control inflammation by reducing the PMN cells and their pro-inflammatory mediators such as interleukin-1, TNF-alpha, and interleukin-8. And response to steroids can be assessed through a model called LIL model, where age, renal failure, albumin, prothrombin time, bilirubin can be looked at baseline and at day 7. And then we can classify these patients into who take corticosteroids And after 7 days of initiation of steroids in patients with severe alcoholic hepatitis, which is defined as MELD of more than 20 or MDF of more than 32, and if these patients have a Lille score of less than 0.45 at day 7, these are called as the responders to steroids, and these patients have a very good survival as opposed to persons who have a Lille score of more than 0.45 at day 7. Unfortunately, a largest trial of prednisolone and pentoxifylline in alcoholic hepatitis patients called STOPA trial have failed to show a significant benefit of prednisolone in improving the outcomes of alcoholic hepatitis patients. And as you can see that the confidence interval crosses 1 and the p-value is not significant, even at 28 days or 90 days. But the point to note is that all the literature, when collated together in a meta-analysis, do show that there is a significant benefit in terms of 30-day survival because of steroids or due to steroids in alcoholic hepatitis patients. Addition of NAC can improve the outcomes of patients with alcoholic hepatitis, and in this network meta-analysis, one can see that the overall survival is better, or hazard ratio of mortality is better in patients who were given corticosteroids with NAC as opposed to no intervention in this network meta-analysis. But mind you, this study was based on only one study. And according to the ASLD guideline, therefore, it is recommended to classify these or the stratify patients with a phenotype of alcoholic hepatitis into severe and non-severe forms. And the severity is classified as MDF score of more than 32 or a MELD of 20. And after ruling out the contraindications to steroids, which include the uncontrolled infections, presence of acute kidney injury, upper GI bleeding, concomitant confounding factors, multi-organ failures and shock, 40 milligram of prednisolone is recommended for 7 days. And then looking at the Lille response, patients who respond, the steroid should be continued. And the patients who do not respond, all sorts of, the experimental therapies and liver transplantation should be considered. It is important to note that there are also something called partial responders, and these are the group patients who have a intermediate kind of survival. Very high MDF scores, more than 90 and MELD, are the kind of patients who do not respond to steroids. And a recent study by Dr. Batala's group, Dr. Juan, as a colleague of mine, has beautifully shown that a MELD score of 25 to 39 is an ideal window where the steroids can be given. But the point to note is that most of our patients who come to us in hospitals have infections, renal failure, and multi-organ failures, which deter us from giving steroids in these patients. And according to this study, they showed that presence of ACLF had actually reduced the response to steroids in alcoholic hepatitis. Several other advanced techniques, I don't think we need to go into these things. And interleukin-22 is another cytokine which is very fascinating. It improves the liver regeneration without affecting the immune system, has shown to be superior to non-treated individuals in a propensity score analysis. However, this is a historical case cohort study, so we need better studies to see the effect of interleukin-22. A lot of experimental therapies of blocking LPS and TLR4 are ongoing, and I don't think it is important to discuss. And GCSF is another experimental therapy that can improve the the liver regeneration. It can improve the immune system. It can improve the clearance of damaged associated molecular patterns, and has been shown by Dr. Sarin's group in predominantly alcohol-associated ACLF patients to have a better survival of 70%. But European study failed to show the survival benefit. Dr. Brijendra Singh, guide of mine, has also shown significantly better survival with GCSF, with or without pentoxifylline, but it is yet to reach a stage of acceptance worldwide, because meta-analysis showed that these studies which show benefit are predominantly Asian studies compared to European studies. And the interesting study from Dr. Jalan's group has shown that when we add TLR4 inhibitor, which is called TAC242 to GCSF, especially in these patients who present to us with acute non-chronic liver failure, there the liver repair and cell death is reduced. And this is kind of a novel therapy which is coming up and being tried in patients with alcoholic hepatitis. Stem cell-based therapies are yet experimental. Targeting bile acid metabolism is also experimental. And there are several trials ongoing because we lack a robust therapy for alcoholic hepatitis as of now, apart from nutrition and abstinence. Organ failures need appropriate care, and we have different sessions for addressing different organ failures in cirrhotic patients. For renal failure and HRS, especially the albumin and terlipressin infusions are recommended. For cerebral failure, one must understand the use of lactulose with or without rifaximin. For circulatory failure, appropriate fluid resuscitation with inotropes. And for coagulation failure, especially patients who are requiring invasive procedures, there only we need to transfuse, especially patients who have a platelet of less than 20,000. Several support devices have been tried in controlling organ failures in patients with alcohol-associated ACLF, have shown some survival, some benefit in terms of hepatic encephalopathy, but it fails to show survival benefit. Plasma exchange is very interesting emerging therapy. We have also tried in some patients of alcohol-associated ACLF, shown improvement in disease severity. From Dr. Maiwal's group from ILBS, they have also shown significantly better survival. And this is a very novel and interesting concept by Dr. Yappan's group from CMC Vellore. Adding low dose of steroids to plasma exchange can improve the survival of these patients. And it is quite interesting to see this as a multicentric study over the next few years. Finally, my friends, I would like to say that patients who are non-responders to steroids, who are worsening, who have multi-organ failures, they can be bridged to liver transplantation, especially when they have a select criteria where the biopsy, they have a first episode of alcoholic hepatitis, they have a strong psychosocial support, they have a commitment for lifelong abstinence, they are absent from any other comorbid physical depression, psychiatric illness, and the family is quite supportive in managing such patients. And there we can, subject these individuals to liver transplantation. And there is a whole lot of debate going on in the community whether to go for deceased donor or live donor. And we can discuss that in the discussion section. And literature has suggested significantly survival benefit with transplant in patients who are not responding to steroids, and close to 90 to 100% of survival in these individuals. Very select individuals who have a very good psychosocial support, first episode of alcoholic hepatitis. These are the kind of patients who can be better with steroids, with liver transplantation. Finally, I will give you the consensus flow diagram by different societies for alcoholic hepatitis. And this is the take-home message from this talk today, that a patient who come to us with a phenotype of alcoholic hepatitis, that is a bilirubin of more than 3 with AST/ALT more than 50 and ratio of more than 1.5, you assess for confounding factors, look for their severity with a MDF score more than 32 as a severe, MELD more than 20 as a severe, assess for their infection, renal failure, pancreatitis, contraindications to steroids, and then start them on steroids. And if these patients with adequate nutrition, obviously, and abstinence and treatment for abstinence, alcohol use disorder treatment, and look at the LIL response at the end of 7 days. If the patient is a responder, that is a LIL score of less than 0.45, continue the treatment with prednisolone for 28 days and then taper it off. And alcohol abstinence has to be ensured at every visit and asked from the patient. And the patients who do not respond to steroids, there are all sorts of experimental therapies referral to liver transplantation center and palliative care is required. The key message here is a person who is not responding at 7 days, whether you gave steroid or whether you didn't give steroid, refer them to a higher center where they can be managed and counseled about liver transplant. European people have also recommended the similar kind of approach. They recommend prednisolone with or without NAC therapy, and they also say that patients who are responders continue the treatment of 28 days, and those who are non-responders, the early assessment for liver transplantation should be done. Dr. Sareen has also added fecal microbiota transplantation or GCSF or experimental therapies like plasmapheresis in the armamentarium with dotted lines in persons who are not eligible for steroids. That is, if they are very high, they have a very high severity at the outset, or the persons who do not respond to steroids if they have a little score of more than 4.45. These are the patients where all sorts of experimental therapies with GCSF, fecal microbiota transplant, plasmapheresis need to be established before it comes into routine guidelines. So friends, summarizing the talk today, alcoholic liver disease is an important entity with high burden. Alcoholic hepatitis constitutes significantly to the healthcare burden globally. Clinical diagnosis of alcoholic hepatitis is very simple with this phenotype of bilirubin of more than 3, as I mentioned. Liver biopsy may be required in a small proportion of individuals. Treatment for alcoholic hepatitis remains suboptimal. Nutrition, abstinence, supportive treatment are the key treatment options. Steroids are only available pharmacological treatment option with 1 month survival benefit, and that too not applicable in majority of the patients. Infections, AKI, high MELD, and MDF preclude steroids in most of the setups across India. And most of the promising therapies include plasmapheresis, interleukin-22, fecal microbiota transplant, GCSF, stem cell-based therapies are the potential avenues for treatment. And pyro concept is something which is a conceptual thing for any kind of disease, I would say. And one must consider at what stage we are managing these patients. And liver transplantation is a definite treatment, must be explored in all patients who are not responding to steroids or who are not responding at 7 days of presentation. Thank you very much. And I would like to thank again NAMS, Professor Sareen, and all my mentors, Dr. Chawla, Dr. Singh, Dr. Dhiman, Dr. Ajay, Dr. Sunil, and my colleagues, Dr. Malumita, Dr. Arka, Dr. Sahaj, and the whole team of ARC who has brought me to this stage, and I'm talking to you today. And I'm happy to take questions from all of you. Thank you very much.
Thank you, Nipun, for taking us through this very interesting area of alcoholic hepatitis and having covered a vast amount of information and made it very easy to understand in a very interesting manner. So maybe I'll set off by asking you a couple of questions or comments from you, and then I'll look out for any chat box questions. So the main treatment that we have as pharmacological therapy is steroids. Now, you have discussed that in patients with severe alcoholic hepatitis, ACLF can happen in a proportion of people. However, severe alcoholic hepatitis and ACLF by itself are different entities, but they can overlap. So the question is, what is your comment? A patient who has got severe alcoholic hepatitis, that means discriminant function more than 32, and meets ACLF criteria as well, would you be comfortable giving steroids?
So, practically speaking, we don't use steroids at our center because we have burnt our fingers. A lot of patients who have come to us, our majority of these patients are having ACLF. So so what literature says, and I'll give you a biological answer also. I would love to give steroids in a setup where there is a good infection control practice, and where you have very low incidence or probably less than 50% incidence of multi-drug resistant bacteria. So these are the two key important aspects. And patients who come to us with ACLF, they are in a severely severe state of immune paresis. And the literature has suggested that, 50% of these individuals with alcoholic hepatitis have ACLF at presentation, and around 25% of these individuals develop ACLF on follow-up. And the definition of ACLF, which I'm talking about, is European definition. This is not a partial definition. Almost every patient of alcoholic hepatitis who comes to us, on the other hand, most of these patients fulfills a partial definition, as you also know that. So I would say a patient who is fitting into the EASL definition of ACLF and 2 or more organ failures, it is completely no for steroids. In grade 1 ACLF, still in a setup where I can manage and look for the infections, and these are the kind of patient I would still try. And biologically, these the patients who have a very high LPS levels or bacterial DNA in their blood, it has been shown in studies that these patients develop infections, do worse, and they do not respond to steroid. So the answer is not yes or no. It is based on the assessment of biological status, the setup, whether you can manage infections, you can follow up, you have a backup of transplant. All these things have to be considered, I think. It's not a simple.
Thank you. So that is very well discussed. So that is the challenges of treating this patient with severe alcoholic hepatitis, many of whom meet the ACLF criteria. And the real concern is about triggering precipitating infections. So if you were to give steroids, what dose would you use? Would you use a standard 40 mg, which is there in the STOPA trial?
Yeah.
Or would you, because the worry is infections,
Yes.
or should you give a lower dose?
So, sir, the answer again is not very simple to this. There is no data at all, except that a study which your group has published, a low dose of steroids with plasmapheresis in improving survival of patients with alcoholic hepatitis, severe alcoholic hepatitis. And I would say that yes, low dose steroids is very important, very intriguing concept. It is a concept, and it has to be tested in randomized controlled trials.
Sure.
As opposed to no therapy or with high dose therapy. I think that is the right answer. What do you think?
Thank you, Nipun. I agree totally with you. And that is how the field is going. And we all hesitate all over India. I recollect 5 or 7 years ago, Dr. Ajay Duseja did a pan-India questionnaire survey.
Yeah.
How many people were giving steroids for severe alcoholic hepatitis?
Yeah.
And it turned out like less than 5 people, 5 doctors. So everyone hesitates in giving steroids because our concern is sepsis. That's a problem in India. That's what the milieu that we face in this disease. I have another question for you. You mentioned, and rightly so, many patients with a high level of jaundice, raised bilirubin with severe alcoholic hepatitis, would go to multiple hospitals and take different medicines before coming to our center, to a tertiary center. And it's common practice to take herbal medicines as well. Now, the person's bilirubin is keeping on increasing, and it's difficult to say the herbal drug caused it or not. So, is the syndrome now severe alcoholic hepatitis? Or is it a CAM that is complementary and alternative medicine induced liver injury, drug induced hepatitis? Or is it both? Is a differentiation, does it make a difference? But more importantly, in such a patient, would you feel it's okay to give steroids? So when I think of it as severe alcoholic hepatitis plus minus DILI, drug induced liver injury, where do you stand?
So the answer to this question is, sir, very, to my mind at least, I am very, very clear that, if a person has come to us with history of CAM, one must see what is the kind of AST, ALT levels these patients are having. So if the ALT levels are jumping above AST, then it is pointed that, something has added on to alcoholic hepatitis, because ALT is somehow it is suppressed in patients with alcoholic hepatitis. And as I mentioned, the reason for that also, that pyridoxal phosphate B6 deficiency. The another thing is the level of OTPT, the AST-ALT elevations in these. If the patients have a AST-ALT beyond 400, then again it is an indicator that drug-induced liver injury has, or the ALP, which goes very high in, because of cholestatic injury, then also it points towards CAM. differentiation is important because the outcomes of concomitant two insults. PREDICT study is one study where they showed in group of ACLF patients, if you have more than equal to one predictors, more than equal to one acute insult, the outcomes are poorer. So added insults to liver in an underlying liver disease because of alcohol and DLE can add to multiplicity of organ failures, and because of two injuries taken together will lead to poor outcomes. So this is the answer to question number 2, and the question number 3 was steroids. So I think for giving steroids, it is recommended as per guidelines that to look for the predominant phenotype. Although clinically we can make a guess that yes, AST/ALT is less than 400 and AST is more than ALT, and then it could be just alcoholic hepatitis. But in a patient who's consuming CAM, one must do a liver biopsy before taking a decision for steroids. I think that's the way I think about it.
Thank you. I have asked you tough questions, or rather questions which will make the audience also to think as to the complexity of the disease that we face and how we would approach that. I would invite any questions from the rest of the audience or in the chat box, if you could put it up. I don't see any questions as yet.
So
good evening, Dr. Shomadi from AIMS. So just had a question. Initial part of the presentation, you told there could be some cases where even in alcoholic hepatitis, the AST/ALT level can increase more than 10 times. So can you just brief upon that? What are the possibilities and how to identify those cases?
So this is something which is unique to alcoholic liver disease patients. Two different presentations which are quite unique, which is rare, but it is there. One is alcoholic foamy degeneration. This alcoholic foamy degeneration was described way back in 1975, I think, where there are a lot of microvesicular fat was demonstrated in pericentral hepatocytes with less amount of inflammation and excessive cell death. So dropout. But there was no fibrosis, there was no decompensation. These were kind of patients who recovered very well. These patients had very high AST/ALT levels, ranging up to 1200 also. And these are the series, at least 40-50 patients they described actually. And they had a better survival compared to other garden variety of alcoholic hepatitis. So it is not common. And these are very, patients who improve within a span of 7 to 10 days. So I would say that this is a very select group, and we don't have a very good studies as to, apart from a biopsy, to say what, the alcoholic foamy degeneration, this is the kind of patients, how they are. And second important presentation, which is quite unique, is apart from garden variety of alcoholic hepatitis disease, alcoholic hyaline sclerosis, which is also called central hyaline sclerosis, where basically the hepatic venules inside the liver near the pericentral area gets sclerosed because of fibrosis. And these are the patients who presents to us with tender hepatomegaly with ascites, and they just mimic the presentation of Budd-Chiari syndrome. And these are the unique presentation we often teach our DM students, but this is something unique one, and this is not for, predominantly this is for DM students, and we teach them these unique variabilities in alcoholic hepatitis. But
okay, sir. Thank you so much.
I'm happy to take any burning issues. I hope everyone understood the concept of alcoholic hepatitis. So, Dr. Yappan, I would like to discuss one few things. As you have been doing a lot of plasma exchange in patients with alcoholic hepatitis, and so what basically determines you or makes you stop plasmapheresis? Infection is obviously one, but how do you make that decision that this patient is probably infected?
Thank you. So as you mentioned, we are increasingly doing plasma exchange for alcoholic hepatitis, severe alcoholic hepatitis. It'll be like, I think, 1 to 2 new patients per week. That's the number. So let me counter that with asking you a question. At PGH Chandigarh in a year, you have an active liver transplant program.
Yeah.
In a year, how many patients with severe alcoholic hepatitis would you do liver transplant?
Unfortunately, sir, till date, we have not done any patient.
So that's the reality in most centers in the world. So among the transplant candidates, severe alcoholic hepatitis is not an easy one to bring up, you see. We can take alcoholic cirrhosis, but not an alcohol-related liver cancer, but not severe alcoholic hepatitis. While at Vellore now, every week is 1 to 2 new patients. So it seems to fit that way well in that group. The specific question was, how long do we continue it? So our worry is infection. So our current protocol is daily for 3 days. That's what we target for the plasma exchange sessions. But in some patients, we take it up to 5 days, or the odd patient up to 7 days. Usually it's 3 days, sometimes 1 day. That's what.
So do you think that von Willebrand levels, factor levels, or probably the bilirubin decline can guide us in stopping the kind of?
Yeah. Thank you. So VWF now is a clinical test for us. It has been for the last 5 years or so. It's ordered on our workstation, and the turnaround time is 4 hours, and it sort of guides our therapy. We think the survival advantage over regular dialysis by using plasma exchange is removal of molecules which are too big to be dialyzed. So dialysis removes molecules up to 60 kilodaltons in size, molecular weight. That's why in renal lingo, they're called as small molecules or middle molecules. So the macromolecules, which are too big to be dialyzed, which is what the plasma exchange would be doing, maybe is one explanation why survival benefit is now coming up in these liver failure syndromes. And one such macromolecule is von Willebrand factor. There are bound to be many. VWF, however, is the largest sized plasma protein in health. So it's one very good example of an inflammatory macromolecule. And we can see in the people who are improving, the levels start coming down. But I can also say it's like ESR coming down in acute inflammation. It is true. But by analyzing it over time, we think that this clogging of microcirculation in vital organs by macromolecules is contributing to progression of organ failure, and unclogging that by this treatment of plasma exchange plus low dose steroid, we think is what's doing the trick. But it's very early days. All of us have to work on this.
Sure, sir.
I think we're running out of time, and I see that the NAMS office bearers are coming on to the next part of the agenda. So may I hand it over back to you?
Thank you, sir. Now I would like to invite Professor Ajay Kumar Sood, sir, Deputy Secretary NAMS, to propose vote of thanks.
Thank you so much. On behalf of National Academy of Medical Sciences, it is my proud privilege to thank both the esteemed experts who have made this session so interesting and interactive for our PT students. So first of all, I would like to thank the speaker, Dr. Nipun Verma, for making the session so interesting and giving practical tips to our students for diagnosis and management. Thank you so much. And we look forward for your next session, which is on, I think, 9th of May. And I am quite sure that our students are going to be benefited from your experience. Our great thanks to person, Dr. Yappan sir, who have been supporting this program right from the very beginning. I can recall you have helped us earlier also. Thank you so much for steering this session and generating a lot of discussion. I'm sure that the questions and the discussion which has been generated will be useful to our students. And we look forward for your support and blessing in future also. Thank you so much. I will also like to thank the students who have attended this session. So once again, I want to make an appeal to all the students that these are the very important sessions. You get the opportunity to interact with the best eminent personality in the country in this specific field. So please ask your question. You can send your question in advance, which you can put to the speaker. And also you can ask your fellow students and your friends to join this session. And the details of all these linkages we have been sending you on the website, as well as to all the registered students. Very informative. There is another information for all of the students that we have started this NAMS newsletter. And one page on this is on Navigate CME. So maybe some of you will like to share your experience. And I will also request our speakers and our moderators that they can also give us suggestions how we can make this Navigate program more effective and beneficial for us. In addition, recently the NAMS has released a series of task forces, and very soon we are going to put it on our website. And these task forces again can give very important clues and very important guidelines, especially to our policymakers. And some of these task forces I would just like to name. Dr. Nipun is expert in artificial intelligence. So we have one task force on artificial intelligence in healthcare. I think you also made a contribution to that. So that report is almost ready. Then there is another task force report where Dr. Ajay D'Souza was the chairperson on obesity and lifestyle diseases. So these, again, we are going to put on our website. Other task forces where we have the expert was on alcohol, substance use disorders and behavioral addiction in India. And another was evidence-based traditional medicine. Sir just mentioned about the role of traditional medicine. Can it be helpful in some of the diseases? So we have a task force expert report, and maybe some of the solution we can find in these. So with these words, once again, I will like to thank all of you for your valuable contribution. And I am really grateful to you on behalf of the National Academy that you could spend so much time with us. Your time is very precious, and we appreciate that for your blessing and contribution and support. Thank you very much. See you next time on 9th of May at 6 p.m. Thank you.
Thank you.
Thank you, sir.
Thank you, dear all. I declare today's academic session as closed.
Thank you. Thank you.